Okay, good evening, Happy New Year, and welcome all. We are starting a series called T21, where every month, 21st evening, we will be discussing a specific topic on GI and women oncology alternating months. So today we are starting with expert peer exchange on GI neuroendocrine neoplasms, and I'm your host. My name is Dr. Viraj Lavingia. I'm a medical oncologist at HCG Cancer Center, Ahmedabad. I'm honored and humbled to be joined by distinguished guests today, Dr. Jagdish Kothari. He is Chief and Director of GI and HPB Surgery at HCG Cancer Center, Ahmedabad. Dr. Shubda Kanere, she is a histopathologist with special interest in GI cancers from HCG Cancer Center. Dr. Vikram Lele, Chief of Nuclear Medicine from Jaslok Hospital, Mumbai. Dr. Bhavna Siroi, lead GI medical oncologist from Apollo Proton Cancer Center, Chennai, and Dr. Namrata Vijayavarga, a young medical oncologist specializing in GI cancers, especially neuroendocrine cancers, from Fox Chase University, Philadelphia. And to lead us all, we have none other than Dr. Senthil Rajappa, who is our today's moderator. I don't think so our audience need your introduction, sir. So once again, the screen is all yours.
Thank you so much, Viraj. Ravindra, can you let me share the screen? You got that flyer on your screen right now. Great. So what we will do till we get bored and Viraj and Ravindra will ask us to stop for the day is to discuss one case. I've got, we'll discuss a longish case and then I've got two, T20s in between, and then I've got a longish and then the T20 in between. So we'll do something like that to make sure the tempo is maintained, because discussing 1 hour can sometimes be a little long. So let's start with this patient. So here is a 36-year-old lady with no comorbidities. She actually underwent a laparoscopic cholecystectomy for abdominal pain, and peroperatively she was found to have liver metastasis. So we can ask, why wasn't she evaluated adequately before? That's a different question, but this is what actually happened. So that's reality. And then after that, she had a CT and an MR, non-enhancing liver lesions, and a biopsy from the liver lesion was showing a poorly differentiated carcinoma, query NET. So that's what the report was when she first was seen. So this is the gross examination and the microscopy. So as always in neuroendocrine tumors, I think getting your pathology correct and then getting your imaging correct is probably the two most important things. So here, let me quickly read this through and then ask a pathologist for the interpretation. Now, the microscopy shows invasive tumor arranged in nests, trabeculae, lobules, and few cords in loose fibrous stroma. Mitotic figures seen are 10 to 12 power 10 high power field. The cells are strongly positive for synaptophysin and chromogranule and weakly for cytokeratin. These cells are negative for HEPAR1. The MIB is actually 30 to 40%. Okay. The mitotic figure is 10 to 12. The MIB is 30 to 40. And the features are consistent with metastatic neuroendocrine carcinoma. Okay. So the first step, I think, is to differentiate between a well-differentiated neuroendocrine tumor or neoplasm versus a neuroendocrine carcinoma. So let me call Dr. Shubhada. Madam, based on this description, would you say this is a carcinoma? Let's leave the IHC for a moment. Is this a carcinoma description, or is this a well-differentiated neuroendocrine tumor or a neoplasm? What would be your interpretation based on the microscopy? Madam Dr. Shubhada.
Yeah. See, actually, the how we discern between a well-differentiated neoplasm like tumor versus a carcinoma is actually by cytology. And they have said oval hyperchromatic nuclei. That's a clue that we are dealing with a high-grade lesion, because usually well-differentiated neuroendocrine neoplasms will have very monotonous nuclei. Only thing is that they have said that the mitotic figures are 10 to 12. That's a bit discordance. Usually, a high-grade neuroendocrine carcinoma should have more mitotic figures, but I can give some allowance to the pathologist because sometimes in a core biopsy, mitotic figures are not so well appreciated. And the Ki67 usually comes out very high grade. So when I see this description, they also say that it's an invasive tumor. So that is another clue that one is dealing with a high grade carcinoma because usually a neuroendocrine tumor is not invasive. So if I consider invasive tumor and hyperchromatic nuclei, these two are the clues that we are dealing with a high grade lesion. Usually if I
Do
see a
you
sorry.
Sorry to interrupt, madam. The reason why I've underlined this nest trabeculae and lobules with few cords and fibrous stroma is, do you typically see this in a carcinoma, or would you say
No,
this is more
no, no,
likely
no,
to be?
no, no.
Yeah,
That's why I did
yeah.
not read that. Though you have
I wanted you
underlined
to
it, I
specifically
did.
read that because I
No,
wanted you
that
to make that
description,
point.
no, that description, which it says like these two are contradictory things in the report.
Correct,
Because if
correct,
you say they are nests, trabeculae, and lobules, that is usually a description of a neuroendocrine tumor. One can get a desmoplastic stroma also in a well differentiated neuroendocrine tumor. And high grade neuroendocrine carcinoma is usually in diffuse sheets. Usually we call it a high grade poorly differentiated
correct,
carcinoma. That's how I would
correct.
describe the microscopy of that. So that is a bit of a contraindication in this, contradicting
So there are correct. So there are some features in this
in
pathology which
this
say it
report.
might be a well-differentiated one. There are some indicators on the report which say that it might actually be a carcinoma. So how do you finally distinguish between a carcinoma? Let's leave the Ki67 for a moment, madam, because that can happen in both. Can you do some additional immunohistochemistry to say this is carcinoma versus a well-differentiated tumor?
Yes, nowadays P53 is one
Yeah.
antibody, and high grade neuroendocrine carcinomas are supposed to be P53 mutated. We don't have ATRX and DAX and RB1 in India, but RB1 can also help because RB1 mutations are also common in high-grade neuroendocrine carcinoma. I think nowadays in US or developed countries, they are doing it very routinely, RB1 and P53 to discern because sometimes it is really difficult on a core biopsy, especially if it is G3 and large cell
Correct.
neuroendocrine versus G3. So people do RB1 and P53 to discern. P53 either diffuse strong expression or null phenotype, like total absence would favor a neuroendocrine carcinoma, so as the RB1 positivity.
Excellent. So that is a very important point. So the first step for all of us clinicians to understand is that you need to distinguish between a neuroendocrine tumor that's well differentiated, because you can have well differentiated grade 1, 2, and 3. In fact, very interestingly, I saw somebody who called me and said, your pathologist is wrong because she has reported well differentiated and said it's grade 3. How can you have a well differentiated that's grade 3? It can happen in a neuroendocrine tumor. It can be well differentiated, but at the same time, it could be grade 3. Dr. Namrata, would you do in your institute, would you do P53 and a retinoblastoma for IHC for all patients, or is it selectively done?
So we actually do it for all patients who we think are high grade. So anybody that's concerning for high grade, for the well-diff G3s, because there are some well-diff G3s which can have P53 too. So if it's clearly well differentiated on morphology, then they tend not to, because that just confuses us a little bit sometimes. But for all poorly differentiated high grade tumors, we routinely do RB1 and then they do the SSTR, so the somatostatin receptors for the lower grade.
Right. Absolutely. So it's always good to do whenever you're in doubt, especially because the prognosis, the approach to the treatment, everything is different depending upon whether it's well differentiated versus a carcinoma. Can I ask you, Dr. Namrata, is your Ki67 automated, or is it the eyeballing that routinely pathologists do in India at least? And then I can ask the same to Dr. Shubhada.
And I think, so here we typically still, our pathologist is an old school pathologist who loves to, who thinks doing it, visually is the best way to do it, but only in the hands of an expert like Dr. Shubhada, right? It shouldn't, if you are somebody who's not, I think the automated one is really good if you're doing it at a center that doesn't see a lot of it. But at the end of the day, if you have an expert looking at it, we have actually our pathologist did a comparison if the automated and he checked it himself after he had gotten the automated, and he actually thought that many times the automated one was over reading,
Okay.
Ki-67 more than under reading it. That's, I think, but if you look at it's it's not the best, it's the second to the best. But if you are at an institution where you don't see too many, it's a very rare cancer. And before we started, we were just talking about how often when a patient with neuroendocrine tumor presents to a higher center, like Viraj was suggesting, that many times they do review of the pathology from outside and then do their here, and then the pathologist says that it's actually a different Ki-67, usually a higher one than what was reported at the outside. So I think if you are at a center where it's hard to get that automated, is really good too. But if it's an experienced pathologist, nothing beats that.
Great. So experienced pathologist, you don't need the automation. So that's the point. Excellent. So Dr. Bhavna wants to ask a question. You could take it, Dr. Namrata or Dr. Shubhada. If the morphology is poorly differentiated, but the P53 and the RB1 are negative, would you say it's well differentiated, or would you still call it a carcinoma?
No, if the morphology is of a poorly differentiated high-grade carcinoma, I would give more importance to the morphology than P53 and RB1, because a high-grade carcinoma is a high-grade carcinoma. And if neuroendocrine markers are there, yes, it is a high-grade neuroendocrine carcinoma.
And at the end of the day, when it comes to clinical, if the person is behaving clinically like a high-grade, really doesn't matter what the pathology shows.
We'll rope in Dr. Lele as we go by. So he will help us to also distinguish to a certain point, as to whether it's poorly differentiated versus not. So, and whenever you have a discrepancy between the Ki-67 and the mitotic figures, we always take the higher value in order to treat the patient. So that's another important. So point number one, distinguish well differentiated versus a carcinoma. You should rely on your morphology to make that initial diagnosis. You will have to do IHCs, especially if you're dealing with somebody who's got potentially a poorly differentiated or a carcinoma. Otherwise, routinely, you don't need to do P53 and RB1 for all patients. If there is a Ki-67, depends upon who is interpreting that Ki-67. It could be just a good pathologist who can do a better job than an automated one. But otherwise, the trend seems to be getting to automated because it can look at many more fields than what a pathologist can normally do. But there are pluses and minuses. But the point is that you should get a good Ki-67. And when there is a discrepancy, you go with the higher value. So that's very, very important first step as far as the diagnosis is concerned. Dr. Lele, FDG PET, Dotanoc PET, or both?
All right. In the past, we used to, of course, begin with the Dotanoc PET. Of course, we now use Dotatate because Dotanoc is not easily available. Dotatate is everywhere. And then we used to first go by the histology. If we were told that the Ki-67 is less than 2, we would do Dotatate and then stop with it. But as time went by, we are realizing now that it's not so simple. And recently, in every patient who comes to us with a diagnosis of NET, we are doing both FDG and Dotanoc in everybody. And we are finding, this is a sort of a thesis topic for one of our students. And we are finding, surprisingly, that many of these so-called Ki-67 90, figure of 90 has been sent to us. We are finding extremely high expression of somatostatin receptors. They are literally lighting up like a bulb with SSTR when we have been told it is Ki-67 90. And when we repeat the FDG with them, the FDG is also hot. So we are getting a mixture of both the things. We are getting in the Ki-67 less than 2, most of the time we are getting FDG negative. But when we go to the G2 variety, we are getting a mixed bag. We are getting both positive. And then we have this net PET score, where we have a score of 6, which is now being used by many people, where we compare the FDG uptake with the somatostatin uptake. If the FDG uptake is equal to the somatostatin uptake, it is called NetPET 3. If it's only FDG uptake, it is NetPET 6. So we have a sort of a grading. So when it's only FDG, it is very highly aggressive and there is no somatostatin uptake, that would probably correspond to your true neuroendocrine carcinoma. But we are getting a mixture of various things. So even when the Ki67 is very high, we tend to many times get a very high expression of somatostatin receptors. So I think we should combine every possible information, including the Ki67, the histology, and the metabolic behavior of the tumor and the somatostatin expression to characterize the tumor as what it really is. Because if you call it as a carcinoma and you don't do the somatostatin scan, then in a significant percentage of patients, you might probably be denying them the benefit of PRRT if we find that they are expressing somatostatin very significantly. So I think it will be a routine to do both in the near future.
Great. So I think that's slowly getting to the important point of having a very good pathologist, because if you have a very good pathologist, it could obviate the need for all of this. Bhavna, why don't you take that question from Dr. Namrata, who's asking, do you perform FDG PET and for G2 patients as well? What do you do in your practice? Dr. Lele has made his point saying as much as possible, do it for everybody, in both the FDG and the Dr. Tate. What is your practice, Bhavna?
So, I mean, resources, of course, let's say if the patient is not resource limited, then Ki67 less than 10%, I would just do a DOTA scan. But if it's more than 10%, I would do both FDG PET and a DOTA scan, because we've had, I mean, based on the Tata's data and study, we would then, if the patients have FDG positive lesions, then I would add capecitabine to the PRRT.
Capecitabine to PRRT. We'll come to that a little later. But you're saying if the KI is more than 10, if you had a reliable pathologist and you believe that KI67, more than 10 should be an indication for both. Very good. You're very close to the ESMO guideline, should I say. Viraj, do you do both in your practice?
Yes, sir. Anything more than 10 in an intermediate range, in our institute, we do both.
Very good. So that's what the ESMO guideline also seems to be saying. Yeah, please.
So I would just,
go ahead,
add only one
sir,
point.
Good evening.
Here.
I didn't notice you. Good evening.
Good evening, sir. Good evening. Just one point, when we are treating a patient clinically, and if, as it is mentioned that DOTA or FDG PET, whichever is done, and if it doesn't fit into our fused radiological images, that's where, it pops up into our mind that we are probably missing something, and at some point of time we'll have to add either of the two or both.
That's
Very
exactly.
good. So I think you also.
Right, that's interesting.
Correct. So if something is not lighting up well on one of the scans, then make sure you do the other also. Is that correct? Very good. So good pathologist is important. If you've got a Ki67 that's more than 10, try to do it. ESMO says for grade 2, it's ideally both the scans to be done. If you do one scan and you're not finding the uptake to be as good as what you would expect it to be, make sure you do the other scan. So plenty of clinical pearls for people who are listening today. So these are all situations where we would like to do both the scans. So let's come back to our case. So since we started with a Ki67 of 30 to 40 and FDG PET was done, so that's the liver lesion. There are some other cuts which I'm not showing here, which showed a few other liver lesions also. That's the pancreatic lesion. There is also a lesion in the rib, the 9th rib. So here is the PET CT report. You've got a 19 millimeter lesion in the pancreas. This is FDG PET. You've got multiple lesions in the liver. The largest is 30 millimeters with an SUV of 11.5. Few soft tissue nodules in the left lower lobe of the lung, and the 9th rib also showing an uptake. The SUV is 4.8. So all these are hot as far as the FDG is concerned. So this is what happened. So when she went to another institute, the pathology was actually reviewed, and the blocks that were reviewed said it's a well-differentiated NET, grade 2, and the Ki67, by the time the block went from one institute to the other, dropped from 30 to 40 to 15. And the chromogranin A was 86 nanograms per mil. Okay, so typically what Dr. Kothari was pointing out, we also did a DOTA PET for this patient. This is April 2019. It showed that the liver lesions were actually not taking up. The lytic lesion was a Krenning score 1. So bulky tail of pancreas, we don't know what the significance is. So the FDG PET was more corroborative with the Ki67 than the DOTA-NOC PET that was done. So what do we do ultimately? So you've got a pathology report that is discrepant. You've got the Ki67 that's again discrepant. So somebody decided to call it a pancreatic NET, well differentiated, grade 2/3, because you've got the Ki67 all over the place, liver and bone metastasis. Viraj, you agree with that diagnosis, or you say, no, let's make it only grade 3?
I think in my practice, what I do with neuroendocrine is radiology trumps over pathology. This is one condition where
Radiology trumps pathology.
This is one condition.
We don't like to say Trump. We don't like to say Trump.
So this is one disease condition where I tend to plan my treatment based on the radiological findings rather than the KI index, especially for the reasons we discussed. So this case, I would treat with grade 3 neuroendocrine carcinoma like.
So Dr. Shubhada, you heard what Viraj said, isn't it? He is in the same institute as you. So tomorrow morning, make sure you handle him the way he has to be handled.
Right? No, but see, as far as if I have a Ki67 in a case of 15%, but it is lighting up all over the place with PET scan, and if I don't have P53 and RB1 with me, then there is a possibility that neuroendocrine neoplasms are very heterogeneous, and we don't know where this has been sampled. So I would ask him to go ahead with the PET CT, PET avid uptake, and treat it as a high grade.
Correct. So the important point is that we need to take all of these into consideration before we decide what we want to do for the patient. Pathology, clinical presentation, let's not forget that, what the DOTA-TATE or DOTA-NOC PET is showing, what the FDG PET is showing, and then ultimately come to a conclusion as to what you want to do for this patient. Let's skip this for a moment. Let's go on to Dr. Bhavna. What do you want to do for this patient? So this patient, grade 2/3, FDG uptake is significant. There isn't any somatostatin uptake in the DOTA-NOC scan that we did for this patient. Ki67 is between 30 and 40. Pancreatic NET, multiple liver metastasis, ninth rib metastasis. What would be your treatment for this patient?
So, I mean, Ki67 less than 55%, I would go with capecitabine temozolomide, and would consider doing MGMT as well. But again, Ki67, I would really like to get that reviewed basically, because that is quite important, 40% versus 15%.
Correct, but I think the FDG PET is picking up Bhavna, and the somatostatin, the DOTA-TATE is not picking it up. I think they're reasonable concordance. They're reasonable concordance.
Concordance, yes.
So I think we wouldn't go back to the pathology at this point in time.
Yeah.
So this is what it is. Dr. Namrata, would you also start this patient on CAPTEM, and would you want to do a MGMT promoter methylation?
So yes, to the first question, absolutely. I think everybody would agree that CAPTEM makes the most sense in this case. It actually covers all the different pathology reports that you have gotten too. Like G2, it's a preferred regimen for G2, it's a preferred regimen for G3. Like, you don't leave any room for concern about that. In terms of MGMT, we're still awaiting the ECOG 2211 study, which is, the CAPTEM versus temozolomide alone. And they actually did a really nice job at doing MGMT methylation status in a prospective fashion. We are awaiting the results of that. In retrospective studies and in brain, yes, MGMT has been very strongly associated with the benefit of that treatment. But really, I think clinically, I would probably say that whether it's low or high, I'm going to do CAPTEM right now for this patient, because I don't know that prospectively. I think it's once we get the results from the ECOG 2211 MGMT analysis, I would probably more try to do it if that comes back positive more than right now.
Absolutely.
I think in that study, they are trying to validate whether you do it with IHC or with the methylation.
Right, and then they're going to also correlate it with PFS as the primary endpoint. So I think both of those.
So I think correct. So the glioblastoma data is that it's prognostic. People who have a promoter methylation do much better, but still patients who don't have it also tend to benefit from the regimen. So we would not change our treatment based on whether somebody's got a promoter methylation or not. So that's an optional thing. Viraj, ninth rib, there's a lot of pain. Would you add radiotherapy, and what's your experience with doing radiotherapy for these tumors?
So solitary bone meds, if it is painful.
Painful bone med.
Definitely one could consider radiotherapy. And like mentioned here, I would also add a bone modifying agent like a denosumab. But yes, radiation I have done in these patients for palliation of pain, definitely.
Right, but I've always found that the efficacy hasn't been so very great, Viraj. Though I always, in desperation, go ahead and do radiotherapy, especially as the Ki-67 keeps dropping down. You come into that grade 2 area, you find that you're radiating, but there isn't much of an efficacy. All right, great. So let's move on. So grade 2/3, 30 to 40% FDG uptake, DOTA is negative. Patients started on CAPTEM. We did radiotherapy, denosumab, and after 3 months, this is what you see on the scan. Though there isn't a major increase in size, mild increase in size in the left hilar lymph node, no significant increase in size in the other areas, but the metabolic activity is still going up 8.2 to 10.4, 2.6 to 3.1, 11.5 to 9.7. That's the only area where it's come down. And we did radiate that rib, so that's come down a little bit. Viraj, what do you want to do? Continue CAPTEM? Patient continues to have pain in the rib. Otherwise, the other areas are asymptomatic. Do you want to continue CAPTEM or look at something else at this point in time?
At this point in time, I would continue. So by this time, patient has 2 cycles, right? 2 months.
3 cycles. So
3 months.
2 or 3 months. I think it's 3 months.
I would. I sense that this patient has a heterogeneous disease, but for now, I'll continue CAPTEM.
What's happened to the chromogranin?
Great. So do you routinely follow up chromogranin, Viraj?
No, I don't
routinely, because everybody is on a proton pump inhibitor here. It's actually a co-prescription for anything that you do in India.
Right.
So, that's the most difficult thing for me to follow. So sometimes I don't even do it at the time of diagnosis. But, if you are very strict on that. Yeah,
there
please
was
go
a
ahead.
study where they did like chromogranin levels on 50 healthy volunteers and 50 patients with neuroendocrine tumors. The average level of chromogranin was actually higher in normal people than it was in the patients with neuroendocrine tumors.
Great.
It was just such a weird and eye-opening study that my fellow showed me.
You're absolutely correct. I'm very skeptical about chromogranin. Now here starts the story again. So this patient moved from Hyderabad to Qatar because the husband actually moved there on job. And as soon as they went there, this is 6 months after CAPTEM, they did a dotatate scan there, and look at what this is showing. Now the liver lesion is actually showing intense tracer uptake. Okay, I read this report twice, thinking whether this is an FDG PET or is it a dotatate. It clearly mentions, so that's why I've underlined the dotatate at the top, just to make sure that we are not misreading the scan. Now the left hilar lymph node is showing intense uptake. There are some lesions that are showing mild DOTA uptake. So everything that was FDG is now becoming DOTA positive. Dr. Lele, does this happen? Can this happen at all? Because the initial scan did not show anything at all. Now the patient, just like the block, became 30 to 15% when it came from one hospital to the other. On the flight, it looks like the FDG became DOTA up. Does this happen, Dr. Lele? Is this consistent?
This is very unusual. I've seen the other thing happen, that DOTA becoming negative and FDG become positive. But FDG positive and DOTA negative becoming DOTA positive is rather unusual. I'm trying to think of what could have happened, whether there was some technical issue with the previous DOTA scan. But that's also not, it's a fairly hardy isotope and you can't really go wrong in the synthesis. So, you are trying to say something, Dr. Lavingia?
Yes, sir. My question is, does the dose of DOTA injected during the scan impact any of these results?
Not really, because even if you give a very small dose, normally we give around 3 millicuries of dotatate or DOTA-NOC. But many times the receptor density is so high that even if you give half a millicurie, it is enough to go and make that lesion lighter. So the dose doesn't matter. The only thing which can matter is poor labeling. something has gone wrong with the synthesis. So we always look at the scan and to see if we are seeing the pituitary gland. If I don't see the pituitary gland, something is seriously wrong with the labeling, then I would want to repeat the scan. I don't have the images of the previous scan to see if the pituitary was visible. But if it was visible, then it becomes a strange case that it's changing its character. It would be reportable. I've never seen it in my practice so far.
Correct. Very nice. So have we. Or rather, so haven't we, should I say? But this is what happened. So Viraj,
until one thing is interferon. If you give, so I've had a couple of patients where we've given them interferon and they've become from DOTA negative to DOTA positive, based on Dr. Shell Oberg's experience. And not sure whether this patient had a lot of viral infection.
No, nobody. This didn't have anything, at least as much as I know, because this patient is very much in touch with me, so I know what's happening. So nothing actually happened. So Viraj, what do we do next? So this has become suddenly DOTA avid as it went over the Arabian Sea. So what shall we do next?
So my best guess would be, of course, I would like to have a surgical consult here, since this is just left lobe of liver involved. In all DOTA avid disease, in low grade kind of disease, we tend to like debulking of the liver lesions because that helps PFS.
This patient is asymptomatic, Viraj, asymptomatic except for the little bit of pain in the 9th rib. So remember, pancreas, and then a few liver lesions, left hilar lymph node, a few nodules in the left lower lobe of the lung, and a 9th rib. So you have that many. I don't know. Let's ask Dr. Kothari. Dr. Kothari, would you want to consider this patient for debulking, asymptomatic, no carcinoid syndrome?
Before that, probably I am reading a couple of other things in this report. One of it is what you have mentioned is that the focal uptake in the pancreas is more likely physiological DOTA uptake. Now, if
we'll come to that. This changes over time.
My only memory is that this uptake generally happens in uncinate process, and our patient does not have probably uncinate process lesion. That's the one thing which now coming back to the question which you have asked, I think you are right that this gentleman has got probably other priorities simultaneous, and liver is not the only thing which is bothering him. So before jumping on to surgery, I would consider other options, medical management as well as managing the liver. If it is bothering him, I have now more arsenals to deal with the liver lesions as well. So not surgery at this stage. Yes.
Okay. Dr. Namrata, what's your next step? Yeah, Dr. Lile, and then Dr.
I've
Namrata.
just got an input. It looks like your program is very popular, so it's been seen by a lot of people. So I've got an input from my consultant and from RMC also, that this has been described after CAPTEM. And Dr. Sandeep Basu over there has shown 2 cases, and Dr. Rodney Hicks, who's from Australia, who's got a huge experience in this, has also shown the case. And the explanation is given is that the high metabolism clone responds to the CAPTEM, and the clone which now becomes evident is the SSTR positive one. It sort of gets unmasked. So there have been cases which have been described. That's a learning for me also. So this is
very good. It's a learning for all of us.
Right.
Very good. Excellent. So I think it's worth, we've learned at least one good point today, if not anything else.
Looking at my phone, I got an input from my consultant, Dr. Karuna Luthra. She's been talking to Dr. Sandeep Basu, who's treated thousands of cases in radiation.
Great. I'm so happy we have learned something in addition. Dr. Namrata, what is your next step on this patient?
Well, I think so. First, the question coming back, I have seen people who have had both positive, and then one of them becomes negative and the other one becomes extremely positive. To see to an extent that was completely negative and now it's like really high tracer uptake is something that's really, really uncommon to be said that.
Yes.
I think I agree. They started the sandostatin for this patient. That's really good. That's something I would do. The patient is in a lot of pain, has disease outside the liver. I actually do think that CAPTEM is still appropriate for this patient, right? If the patient is progressing, I just didn't see that there was actually progression seen on the scan. I would just add, sandostatin to the mix, but
to the
probably not
CAPTEM.
stop the blood.
Yeah.
Okay, so that's exactly what they did. They actually stopped the CAPTEM and put this patient on sandostatin because the report said it's well differentiated and that's what you should be handling. So this is after 3 months. In December 2019, the Dotanoc PET was repeated. All are stable. The pancreas is showing an increase in the SUV. Okay, so that's what is happening. But at the same time, and then they continued the sandostatin till March 2020. So nearly 6 months, reasonably good health, except for that pain that is still continuing. So a dotatate was again repeated, and this is what it showed. There is now increasing size of the dota-avid hypodense liver lesions, increased uptake in the uncinate process of the pancreas, and left lung hilar lymph nodes. Rest of them are stable. So there is progression on the DOTA scan that was done after 6 months of sandostatin. Bhavna, what is it that you want to do next?
I think I would refer to Dr. Lele for PRR.
You would refer to Dr. Lele. Dr. Lele, would you be happy to straight away take this up for PRRT, or would you say, let us go back and do another FDG PET?
Yeah, I would.
Yes, I would like to see the total picture. If it's still FDG hot, then I would like again a combination of CAPTEM and the PRRT to be given. If the FDG is not hot, then I would go only with the PRRT, especially since the size has increased.
But the patient has already progressed on CAPTEM systemically. Not sure what's the point of doing that now.
That's true, but this synergy is more important. The CAPTEM probably sensitizes the tumor for the action of the PRRT. So
as a radio,
so you're saying that
yeah.
Okay, so we could all, debate on whether there is some radio sensitization by capecitabine and temozolomide. I'm not too sure about that, but the CAPTEM was anyway stopped. So this is the FDG PET. It's also showing intense hypermetabolism. This was done in the same center by the same nuclear medicine physician. There is some mild FDG activity in the rib. More conspicuous FDG PET suggesting dedifferentiation now. So these are two scans done at the same time. Both the FDG PET and the dotatate, both of them are taking up the dye quite strongly, and there is enough radioactivity demonstrated. So, Viraj, what is it that you want to do now? Rebiopsy? What therapy do you want to do? So there is intense uptake both on the FDG and on the dotatate now.
So, like I mentioned, this case gave me a sense of a mixed picture from the beginning. At this point, I would go with just plain chemotherapy and take care of the high-grade part first, and then move for PRRT for the DOTA uptaking.
What chemotherapy, Viraj, now? CAPTEM has been used. 30 to 40% is the at least pathologically demonstrated highest Ki-67. What chemotherapy do you want to do?
So VP16 and platinum, that is what I would do.
What is the response rate for somebody like this with VP16 platinum, Viraj?
So based on the Nordic study, we know that less than 55%, the responses are not good, but we still find responses.
Would you still want to lay your hands on, streptozotocin 5-FU or, Folfox, Folfiri, any of those things?
So I just learned Folfox is good for GI, intestinal malignancies, neuroendocrine, rather than pancreatic. That's my take, but Dr. Namrata can...
Dr. Namrata, what chemotherapy in this patient?
I probably do Folfox here too. I think...
you will do Folfox here.
I think, we were talking about a case like this before, and in general, like for the pancreatic G3s that are symptomatic, I prefer CAPTEM. For the non-pancreatic G3s and I do Folfox, but but that doesn't mean Folfox doesn't work for the pancreatic ones too, but it's just not my first line of choice. For a patient like this, I would totally, Folfox would work really well for this patient. But I actually would want to go back and do, if the patient is completely asymptomatic, this is the window where I think PRRT could be done. You have time to do it. And if and when she progresses after the PRRT, now you've taken care of the DOTA positive, you could do Folfox afterwards too. So there's
so you would do sandostatin, and then you would want to continue the CAPTEM here and then do the PRRT also along with it. So do as many things as possible at the same time, trying to attack the FDG and also the dotatate that's picking up. Very interesting. All sorts of things that can be done simultaneously in a patient like this. So for people who are listening, though, carboplatin and etoposide is also one of the choices. In fact, that's what they did for this patient. But as Dr. Namrata was saying, the other choices would include something like FOLFOX or FOLFIRI also, because there is some data to support that. As Viraj rightly said, when somebody's got a Ki-67 of less than 55%, the response rate to carboplatin etoposide is somewhere around 30-35%, in contrast to what you would get with somebody who had a high Ki-67. So this patient was started on etoposide and carboplatin, like what Viraj said. Sandostatin was continued. And very nicely, there was some stable presentation of the pancreatic head uptake, FDG, avid liver metastasis, small lung lesion. There was some amount of stability, and there is stable to decreasing intensity on the DOTA scan also. So the carboplatin etoposide seems to have worked for both the DOTA and for the FDG. There is some improvement that you're seeing in both these scans. So that's what they did there. The burning question always, Dr. Namrata, how frequently would you do something like this? This is something that our people are very crazy about. Whenever
really?
you have a problem, immediately send it for next generation sequencing. It'll give you the answer to all your problems. So what is your thought on doing something like this for a neuroendocrine tumor?
I actually typically do it only once when at one point in time, not usually on the first line therapy, like when they're around in the second line treatment. Using tumor, monitoring of tumor profiling is, I think, more lucrative when somebody is on targeted therapy, because that can help you define the mechanism of escape from that therapy. But doing a serial, these are important mutations, P53, RB, KRAS. These are mutations that are driver mutations that don't change over time. So trying to keep doing that over time is not really helpful, in my opinion. And I just do them once and that too mainly for the G1s and G2s are really very bland. I don't, we have published our own data.
Correct.
For them, I don't even do it.
Right.
In
so
routine
you should, I think you're absolutely right. I think we should do it very, very selectively, because most of the time you don't know what you're actually looking for. You're waiting for some surprise to pop up and something that's going to make a difference, hopefully, in the life of your patient. But that's very, very rare. So what happened to this patient after is that they stopped the carboplatin etoposide, and for some reason, the oncologist, they decided to put this lady on maintenance everolimus. Now, there is some data that sandostatin plus everolimus may not be a great thing to do at the same time, but that's what they did. So this patient is now on everolimus 5 milligram once a day, because she could not tolerate 10 milligram, which is what is the case with most of our patients. So that's the roller coaster that this patient and her scans actually went through. Most of the time, the patients seem to be okay, which is the case in all of our neuroendocrine tumors. We seem to be chasing scans and Ki-67s rather than treating the patient. So that's one interesting case. So let's move on to the next one. So let's go to the PRRT in the next case. So this is for Dr. Kothari, something that the surgeon might want to have a look at, not necessarily a go at. So this is the 48-year-old investigated for anemia, no other symptoms at all. Upper GI endoscopy showed multiple sessile lesions in the stomach. That's the endoscopy you're seeing on the right side, a couple of those lesions that are pointed out with the arrows here and here. Biopsy was a neuroendocrine tumor, well differentiated, no controversy here, grade 1, Ki-67 is 2%. We did see that there was iron deficiency anemia that was corrected. B12 was low normal. The rest of the stomach mucosa looked quite okay, not somebody like an atrophic gastritis. This patient is a vegetarian, which can explain why the B12 was deficient. So let me ask Dr. Kothari, sir, would you want a gastrin level and a Dotanox scan in this patient whose CT scan was otherwise normal? Okay, for whatever reason, the referring physician actually did a CT scan. And what would you do to these lesions that are sitting there, grade 1 neuroendocrine tumor?
So, I'm reading one important line which says that a few tiny sessile polyps noted.
Yes.
One is 1 by 1 centimeter. This is, so I believe that this is the largest, which is described here, and others would be probably smaller than this in size.
Right.
So at this stage, I think going into further history 48-year-old gentleman, whether there is a history of PPI, long-term use of PPI in this patient or not.
That, at least, no, not really.
Right. I think, you have done this endotanoc scan.
Yeah, we haven't done a Dotanoc. So my question is, would you want one? Because the CT scan was normal.
Yes. So, I would not jump into doing the Dotanoc scan at this stage.
Great.
The largest is just 1 by 1 centimeter. I would reassure this patient and call them after a couple of months, look for the symptoms, any further anemia, and then repeat the endoscopy. And looking at that endoscopy, if it is same or regressed, I would still do only follow-up of this patient, because 1 by 1 centimeters gives me that confidence that I can continue to put this patient on surveillance and not jumping into it. And I'll continue to talk to that patient that it is not necessary to panic at this stage.
Absolutely agreed with your opinion, Dr. Kothari. So that is what, very nicely, the person who did the endoscopy also went and cauterized that, wherever there was a suspicion of a bleed on top, and then finally that stopped. There wasn't a drop in hemoglobin again. So this patient's, B12 was corrected, the iron deficiency was corrected, the hemoglobin picked up, and he is actually on follow-up. Now we suggested that we shouldn't do anything. So just to complete that, when would you do an endoscopic mucosal resection, Dr. Kothari? When would you refer your patient for something like that?
So as you have mentioned in this patient, anemia, if I find on my endoscopy that this is the bleeding area and it is bothering and further drop in the hemoglobin level, I would advise that kind of endoscopic resection. But most likely they would not bleed significantly, which would warrant endoscopic resection in these neuroendocrine tumors.
Correct. So we would do a EUS and then check what's the thickness of the tumor, and then decide to do a endoscopic mucosal resection if that patient is fit for that. So the point in this case is that you don't have to go about operating or treating all your patients with neuroendocrine tumor. Sometimes treating the symptom and watchful waiting would be the wise thing to do, because otherwise this patient would need a major intervention, because there are sessile polyps all over the stomach. And for somebody with a grade 1 tumor with just anemia going and knocking the stomach off would be too much of a treatment. So Dr. Kothari is absolutely correct when he says that observation is the best way to go to in this patient. So you want to make a point before I move on?
Yeah, just want to complete what I discussed. I would simultaneously like to look for any other reason for the anemia, because this may not be the sole cause for the anemia.
The colonoscopy was normal. The colonoscopy was normal in this patient. Yes.
Okay.
So that was
and
number two is deficiency, nothing else. Yeah.
Okay. And number 2 is that I would when I said qualifying statement of 1 by 1 centimeter, because there are 3 categories: one less than 1 centimeter, between 1 to 2 centimeters, and more than 2 centimeters. If it is more than 2 centimeters, I have to go ahead and do investigations and treat that patient surgically. 1 to 2 centimeter again is a window, which is a borderline window, and I would look at other parameters and move on. That's what I would complete.
At our center, anything between 1 and 2 gets EMR'd, and then we watch it.
EMR'd if it's 1 and 2, right? So
that it doesn't grow bigger and you don't have to do the surgery, because greater than 2 EMR is probably not possible. High risk of perforation.
It's difficult to do. Absolutely correct. So that's a point very well made. So we'll move on to.
And as well, I would like to do lymphadenectomy, probably if it is more than 2 centimeters.
If you decide to do so, yes.
And then check the gastro level. Just, I know we are rushing, but the type 1, 2, and 3 that also helps us decide whether how closely we follow them.
Correct.
So
this looks like the typical type 1 indolent one that at least based on the endoscopy that we're seeing. The typical one that you're pointing out to Dr. Namrata would be a big polyp that we are seeing. That's the one that's typically associated with poorer prognosis and high gastrin levels. Okay, good. So COVID times have always surprised us with all the things that it brought with it. So this patient was during the COVID time. It still continues to be COVID time for you and us. Cough for 1 week, suspected COVID, and underwent a HRCT, and then obviously found a mass. Then he underwent an FDG PET, which showed the big list of things that I put up there. A 5 centimeter mass in the right upper lobe, a small volume mediastinal nodes nodule in the medial limb of the right adrenal gland, nodule in the lower pole of the right thyroid, soft tissue involving the tail of pancreas with perilesional fat stranding abutting the jejunal loops. So on the FDG PET, they said query MEN. So that was the diagnosis. So we went chasing the lung first. So the lung turned out to be a non-small cell carcinoma. The TTF1 was positive. Later, chromogranin and synaptophysin were done, both of which were negative, and the CK was also positive. So it was not a neuroendocrine carcinoma there. It was endocrine. We also did a DOTA scan. This is what the DOTA scan showed. It's showing uptake in the tail of pancreas, small lesion in the uncinate process of the pancreas, a peripancreatic lymph node, adrenal gland, which is also showing increased uptake, but the thyroid probably the parathyroid in this case is showing very faint tracer uptake. The lung obviously is not. So the pancreas is taking up, the adrenal is taking up, the parathyroid, faint uptake, and the lung is not taking up as it is expected to be. Dr. Lele, what would be your interpretation in this case? Do you think this is a multiple endocrine neoplasia that we are seeing? These are the scans. I'll give you a few seconds to have a look at it. We are running short of time. So there's an adrenal lesion, and this is the Dototox scan. So that's the parathyroid as given by our nuclear medicine physician. So please pardon me if the arrow is in the wrong place. And then this is the lung lesion that we are seeing. And then the pancreatic lesions that you're seeing in the cuts in front of you. So what would be your interpretation, Dr. Lele?
All right. So you have the parathyroid, you have the pancreas. So two lesions are definitely there. The adrenal, I'm sorry, can I see that slide again for the adrenal? I missed it.
Yes.
Yeah, there is a right adrenal lesion.
Correct.
It is picking up. Let me see. Yeah, of course it's picking up. So yes, I would agree that you have adrenal, you have pancreas, you have parathyroid. So you do have multiple positive lesions on the scan.
Okay, great. Right. So there is a suspicion of a multiple endocrine neoplasia. Bhavna, what would be your next step in this patient? So lung carcinoma, and then you've got three areas: pancreas, the parathyroid, and the adrenal that's showing up increased uptake on the Dototox PET CT scan. What would be your next step?
So I think would go for biopsy, and also I would do some blood tests like calcium, prolactin, pituitary. I think we need to look for as well. Prolactin, maybe chromogranin A as well. And you've done the biopsy from the pancreas already. So those would be my next steps. And,
so pancreas is well differentiated, grade 1, parathyroid suggestive of adenoma. Adrenal biopsy was not done. The upper GI endoscopy showed just altered mucosa D1, D2, and the pathology turned out to be some hypertrophy of the Brunner's glands. All these are normal. Everything that you asked for, except probably the chromogranin A, is normal. We didn't do a prolactin level. The cortisol is also normal. So what would you do with this patient? A lung cancer, clinical T2N0 with these three tumors.
Is it the serum calcium, is it free, or that's sort of a low if it's total?
So the albumin was low. So the corrected calcium is somewhere around 8.5.
Got it. Okay.
Sorry for that. Correct.
So
all the other values. Yeah, go ahead.
So the patient has, you said T2N0 lung.
Yes.
And T2N0 pancreas. All of them are. So I would go for surgery for all three. And how we do it, I'll discuss in an MDT.
Dr. Kothari, surgery for all of them or surgery for the lung and wait on the others?
So the lung takes priority because of because it's adenocarcinoma. And then we go for the others.
I was wondering that we need to give a priority to the lung problem, and this neuroendocrine tumor can wait at this stage, because that's what I would do. Lung is the first thing.
That's
And
correct.
the
So
only
would
thing
you
I would
offer?
say, not both.
Absolutely. I think that's the point that I was wanting you to certainly make. Dr. Namrata, you agree with Dr. Kothari that you just handle the lung and leave all the others alone for the time being?
For the time being, yes. But only for the
Good, for the
time
time being.
being. One, it will
Yes,
progress, and these things, he'll have
keep
multiple
keep
lesions. So
chasing. Yes, so we'll keep chasing them and making sure that the patient is under follow-up. But I think I totally agree with Dr. Kothari that at this point in time, handle the lung and then leave the rest because none of them are functioning. But the problem is that typically in an MEN1, you would get somebody with a primary hyperparathyroidism, which is clearly not the case in this patient. You usually get multiple areas of the parathyroid that are involved, which is again not the case in this patient. So there are some features anatomically fitting in with MEN1, but typically not based on the biochemical and pathology that we have on this patient. So that's the reason why I wanted to show. Dr. Amrita, would you do a genetic workup on this patient or you would not?
Definitely. That's something you probably can start doing at some point in time. Affects the patient, affects your diagnosis, and also affects family members. So I think the one thing that I would do for the men right now is to send him for genetic counseling.
Correct. So we have sent for a germline testing. So we just need to wait and see if he's got the mutation in chromosome 11, menin protein, which is supposed to be mutated in this particular case. So let's wait. But there are many other areas, many other loci that are described, which are supposed to be mutated. In some patients, you don't see the mutation at all. So you've got all sorts of things that patients actually come with. Great. So so this is just to demonstrate that when you look for something, you will find it, and then all these things come as a surprise sometimes, and then you need to use your wisdom to decide what should be handled first and what probably need not be handled at all till they show up and then are symptomatic. So that's the reason for showing this case.
Something else,
Pardon me, sir?
Not MEN, but something else like VHL, because we are seeing
not correct. So not
cerebellar, kidney, and neuroendocrine.
You have pancreas, you have, we don't of course have pituitary here. So it's a sort of a mixed bag. You don't have.
Correct. So it's a part of MEN2 and a part of MEN1 if you look at it from that standpoint. But you don't have the medullary carcinoma of the thyroid that is typically an association or a part of MEN2. So that's why I said, it's a mix and match of MEN1 and 2. And that's exactly why we are not too sure. Is it just to be called a multiple endocrine neoplasia or typically a syndrome? So that's the confusion. So we will wait for things to evolve and then we will know. Yeah, please go ahead.
I have a patient. I know you're about to, but I have a patient who has a pancreatic NET and severe hypercalcemia, but doesn't have MEN1, and his thyroid parathyroid is absolutely normal. It's just an ectopic secretion. So tons of different things.
So I think when you're labeling it as a syndrome.
Are we comfortable with leaving a more than 2 centimeter pancreatic lesion, even though it's grade 1?
Dr. Kothari, leaving behind a.
For now.
Yes. So I think we are fine with that as long as we will monitor what is happening to that, because going in for surgery for the pancreas now would be something big.
No, you have to do it as a staged procedure, probably.
Dr. Kothari, your last word before we move on.
Yes. So once I have handle the lung problem carefully, then of course I'll once again come back to pancreas. Yes.
Okay, so we'll think about it later, not necessarily as a priority procedure at this point in time. So we'll go to our next case and then probably Dr. Namrata, you have time to stay with us, or because it's 8 o'clock here now?
15 minutes.
Another 10 minutes? 15 minutes, great. So we'll finish it by then, because my wife is saying dinner is called already. So if I don't go on time, I don't get my dinner. So we'll send you to your clinic on time. Okay, 50-year-old male initially presented with pain abdomen, underwent evaluation for acid peptic disease, found a nodule in the duodenum, query neuroendocrine tumor on the biopsy. Ultrasound showed multiple SOLs in the liver. CT scan confirmed the same. No controversy on the biopsy. This is NET grade 2, but a Ki67 of 4%, very close to 1, I suppose. And then this was the scan, the DOTA scan that was done. The final diagnosis is well-differentiated NET grade 2 duodenum with multiple bilobar liver metastasis. So that's what it is. This patient did not have an FDG PET. Okay, so Viraj, do all patients need immediate therapy? This patient is probably got some acid peptic symptoms, not really something to do with what you're seeing on the scan. So the question is, do all patients need immediate therapy? Who can be observed?
So exactly like this patient, if this patient gets better with PPI, I would tend to observe this patient. He has no symptoms regarding his liver, which is the major bulk. So
Correct.
these kind of patients can be observed.
And how do you monitor these patients on observation? Scans or, chromogranin, if you would do that?
No, so 3 months physical exam, and once in 6 months I do DOTA scan on that.
Very good. Bhavna, when would you start this patient on long-acting somatostatin analogs if you did?
So I think I would look at the tempo of progression, and I
Right.
normally do chromogranin, and if it jumps up and that triggers a scan, and based on the serial scans or chromogranin, if the patient becomes symptomatic or if there is a rapid progression, those would be my triggers for PRRT actually, not for octreotide.
Okay, so you would straight away go off to PRRT. You wouldn't give this patient at some time on sandostatin, octreotide, whatever. Is that what you would do?
So I think because once you start them on these drugs, you have to keep them on for life. And most of our patients fund these drugs themselves. So at least PRRT is a one-off procedure.
Okay, so you are saying that you would go for PRRT upfront. Dr. Namrata, would you agree with that? And I also want you to take that other question. Is one long-acting somatostatin analog better compared to the other? Because here in India, we don't have experience with the pasireotide and lanreotide. So would you straight away go to PRRT? That's one question. Is one better than the other? That's the second question.
We wouldn't go straight away PRRT, and the biggest reason for that is insurance won't approve it here. You have to have progressed on a somatostatin analog to get PRRT. That's the way the drug is approved here. So we absolutely wouldn't do it. And to the point, I typically after PRRT, like once the patient progresses on PRRT, I don't continue my SSA on like when I'm on to biologics or oral therapies typically. I do agree that, I think if you are thinking of cost effectiveness, I like idea of Dr. Purohit, but I've seen so many bad things happen with PRRT2 patients. I had got my first acute Luke diagnosed after PRRT2. So I'm like very, very hesitant to proceed with it, at least first line. And in terms of which SSA I use, there is no difference. Our pharmacy cut a deal with one of them at a better price. We just use that one.
So you are as good or as bad as us, I suppose, when it comes to things like this. Okay, so I would agree that we would put this patient on sandostatin as the first line. I mean, some long-acting somatostatin analog as the first line therapy. Let's not forget that PRRT is also not cheap. So the generic ones are now available if you want. So yes. So if you typically go by the book, it's sandostatin first and then PRRT afterwards, because that's what the NETA also clearly
PRRT
yes.
is 15,000 to 20,000 rupees compared to 20,000 rupees per month.
We'll come to, I'll let Dr. Lele have that final word on what is the cost of PRRT and what's the best thing and so on and so forth. So what happened to this patient is that there was good response, which is something that's very unusual to see on PRRT. So this is, not PRRT, on sandostatin. So the scans on the left were at diagnosis. The scan on the right is after 6 months, nearly a year of sandostatin only. And you're getting such a lovely response, which is not something that's typically what you see when you put these patients. The partial response rates that are reported in the literature is about 6 to 7%. Most of them would have stable disease, and the progression-free survival is better for patients who took the sandostatin. Let me go straight to Dr. Lele there. And this chromogranin kept going up, and for some reason, the person who was treating put this patient on carboplatin and etoposide, which should not have been the choice for a patient with Ki67 or 4. So when this patient progresses, do all of us agree, Bhavna, Dr. Namrata, and Viraj, that the next step should be to go to PRRT straight away?
Yeah.
Yep.
Progressing on sandostatin. Okay, all of us agree. So let me go to Dr. Lele now. Sir, so the patient is all yours. This is the scan that we are seeing. Plenty of uptake on the dotatate scan. So is this your ideal patient for PRRT?
Certainly is. He's certainly progressing. He's got bone lesions also. and he's got very, very avid disease, SSTR positive disease. So no doubt he'll do should do very well with PRRT. What we do is we combine PRRT and LAR together. I don't think we do it independently, because the NETTER trial
Correct.
was both together and not separate from each other. And
so, Dr. Lele, if I can interrupt you for a moment, can you tell us how you schedule your sandostatin with the PRRT? Because you made a very important point, because people think that it's contraindicated. So I want you to clarify on that.
Yeah, not really, because initially the thought was that if you give long-acting, if you give LAR, and then you cannot schedule your PRRT for at least 3 weeks till you give the next dose, just before you give the next dose. But there have been several studies now which show that it really doesn't matter. In fact, the uptake of the receptor uptake increases after you give sandostatin, because the background goes down and the uptake in the lesion goes up. So contrary to the prior belief that the uptake in the tumor will go down because it will get blocked with the cold sandostatin, it really does not happen that way. So nowadays, not really insist on waiting for at least 3 to 4 weeks after a sandostatin injection before we give the PRRT. It doesn't matter. You may give it within a week, you may give it within 2 weeks, depends on the convenience of the patient. So it, as far as the effectiveness is concerned, it makes no difference. And there have been enough scans which have been done, a DOTA scan done in the beginning, then LAR given, the DOTA scan repeated after a week, a DOTA scan repeated after 3 weeks. They have shown that the uptake by the lesion does not go down. In fact, the uptake sometimes goes up. So that is now well established that it doesn't matter. You give statin and you can give your PRRT at whatever convenient time you want.
So what is the response to PRRT? How many cycles would you generally do, Dr. Lele?
Nowadays, we would like to give at least 4 cycles at an interval of 3 months. And we must combine them with the PRRT, and we give a standard dose of around 200 millicuries. And as far as the cost is concerned, which Dr. Bhavna was saying, we have a spectrum of costs in India. We have the Radiation Medicine Center where you have 10,000 rupees and you get 1 cycle done. You have a private hospital in Bangalore where you have to spend 3 lakh rupees per cycle. So you have a spectrum. In general, the average in any private hospital, it will cost you something like 1.5 to 2 lakhs for 1 cycle of PRRT. While in a government hospital, it will be 10,000 rupees or almost free. So you have a range. So cost is not really the issue. Many people can get subsidy quite often. The choice is between an imported lutetium and a locally made lutetium. That is the choice. We have an imported lutetium which is much higher specific activity, so theoretically better. We tend to use less peptide when we use the imported lutetium, but of course the cost goes up. The local lutetium, which is given by the Bhabha Atomic Research Center, is very cheap. It costs almost half of what the imported lutetium is. In our experience and in the experience of Dr. Basu at the Radiation Center, in the effectiveness, there's really not much difference between the local and imported lutetium. It's as effective. Theoretically, the imported is better because it is higher specific activity, but in practical purpose, it really doesn't matter. We are getting amazing results even with the locally manufactured BARC lutetium. So,
Dr. Lele, can you comment on actinium? Yeah, just this question and then your question, sir. What about actinium versus lutetium? And then Dr. Kotari's question.
Yeah, actinium, of course, is something which we have started using recently. It is a fantastic isotope. It is 100 times more powerful than lutetium. It is an alpha emitter. So it has a very, very powerful radiation and a very short range. So it is much safer than lutetium. It has a range of something like 80 micrometers, while lutetium has a range of 2 millimeters. So only problem is the cost. An actinium dose will cost you 5.5 lakh rupees for PRRT, while a lutetium dose will cost, as I said, 1.5 to 2 lakhs. And
if somebody can afford, would you prefer that to Dr. Lele?
Absolutely. Of course, we don't have a long-term follow-up and the data is very, very early. but the effectiveness, whatever we have seen, I would recommend that as the first.
Dr. Kothari, your question.
Yeah, so I had just one comment and a question that, probably we are underutilizing the multidisciplinary tumor board for management of pancreatic, neuroendocrine tumors. And my question is that if Dr. Lele was involved in this MDT, would you have preferred to get in PRRT in these patients earlier, immediately after the sandostatin was probably given for 6 months, and then patient got the adequate response to that, and you would have come with PRRT and would have benefited more, is my question also.
Yes. So
early versus delayed.
I would suggest that the tumor burden in this patient was fairly large. His liver was quite studded with the disease. He also had bone lesions. So I would go straight away with the combination of LAR and PRRT together. I would not wait in the beginning, though fortunately for him, he did get a very good response to LAR alone.
But surprisingly also.
Yeah.
So okay. Senthil, definitely I want to re-emphasize on this point that in this country, we are not, we are underutilizing our MDT expertise for management of neuroendocrine tumor, and probably we should definitely widen that direction.
Absolutely, no doubt about it. So that case was to highlight. So this patient had a super response to PRRT and then continues to be on follow-up. So that case was to demonstrate the usefulness of PRRT, when and what, and so on and so forth. So early PRRT seems to be the way to go, and that's absolutely correct. So we've got 3 minutes. So quick answer to this case: 54-year-old doctor.
On that
Viraj,
case.
We'll reserve it after Dr. Namrata leaves.
Okay.
54-year-old doctor, performance status 1, no comorbidities, some abdominal discomfort, huge pancreatic mass, 11.5 centimeter mass, head and uncinate process of pancreas, compressing duodenum, encasing mesenteric vessels, portal vein, filling defect, SMV, PV junction, infiltrating momentum. It's all over the place, but it's just localized. Biopsy is showing well-differentiated neuroendocrine tumor, Ki67 of 2 to 3. Chromogranin is 248. Dr. Kothari, would you want to lay your hands on this patient or not?
It's really a challenging situation. Honestly, this
That's why I'm asking
information is this information is still not adequate for me to jump onto surgery, and probably I'm looking for the excuse of not jumping on at this stage directly for surgery.
Okay, great. Dr. Namrata, I wanted your answer specifically for this. If you are looking at some neoadjuvant therapy or something to downstage and help Dr. Kothari, what therapy would you use in this patient with a Ki67 of 2 to 3%?
I think because it's a pancreatic tumor, we use CAPTEM very routinely neoadjuvantly.
Even for 2 to 3%? 2 to 3%?
Yeah, even pancreatic nets are like very different from GI nets, and they respond. Actually, there's usually a response rate of like 20-25% in this setting. It goes up to 40% for the grade 2s, but we use CAPTEM for the neoadjuvant setting very often. We have also used CAPE with radiation. I know radiation is not really effective, but I have had some good results in that situation too, but in general, that's like a second line. First thing, we typically tend to do neoadjuvant CAPTEM for such patients. That's I want to hear what Viraj and Dr. Cyril talk about.
I would do PRRT, what we've done. Yeah.
Exactly.
Oh, interesting. Okay.
And we've done it in actually 5 cases. Sandeep has talked about it in one of the papers we published. And again, they were all operated, done wonderfully well. You would use a strategy which has 60 to 70% response rate.
But PRRT
Dr. Lele does PRRT, 40%, 40-45%. So, and typically what happens is, though this patient has responded, just like in our neoadjuvant therapy for adenocarcinoma of the pancreas, the tumor shrinks, but it doesn't get off the vessels. That's the major problem. And that's typically what happened in this patient. After 2 cycles of PRRT, tumor has shrunk, but it's still all over the vessels that I actually enumerated. So that was the problem with this patient. So CAPTEM is something that we will try on this patient a little later. This patient went all over the world to get surgical opinions. Unfortunately, nobody was ready to operate except somebody in Japan. And then for reasons known and unknown, he decided to stick on to me. So, so I did PRRT, and this is what we are seeing. It's getting better. So I'm just hoping that it will get even better with a few more cycles, and then we can reconsider surgery. So I won't discuss any more cases, though I've got a couple of them. Viraj, your question, and then we can wind up.
No, my question was, in the last case with so much of liver bulk, could we have considered debulking some of the liver? Which
Dr. Kothari, debulking
so,
surgery in the previous.
Yeah. So once again, I said that we underutilize some of other modalities of treatment. I would do some liver-directed treatment if it is bothering me before jumping on to surgery. So I do have that option as well, and we have treated patients with it. Yeah,
correct. I think you just should not forget your colleague when you're managing these patients. Keep discussing them. In fact, the beauty of this whole discussion that we have had is, when I look back at what I have done for my patients, I always think, oh my goodness, this is what I did. I could have actually done better, with all the other things that are available. And as we are discussing, so that thought keeps coming all the while. And I agree very much with Dr. Kothari that, you should keep on thinking about it, asking your colleague for help, and what is the best thing that you can do for your patient. So in case all
and in last
confusing. Yes, sir.
Sorry. Only, in last case, we also have 2 cases experience of neoadjuvant PRRT and then surgery, but only just for the junior people who are, the students who are with us at this stage, that these surgeries are extremely difficult as opposed to that what we do with pancreatic adenocarcinoma, because there is a lot of fibrosis. Desmoplasia is known in neuroendocrine, and that's what one has to keep in mind.
And that's why our people tend not to use PRRT as much, because radiation worsens the fibrosis there, in their opinion. So they really feel that if you're thinking neoadjuvant approach, tend not to use periop, and that's why perioperative PRRT is not it's not, here we have to go by what insurance approves. PRRT, one dose is $50,000 here in USA. So it's
only $50,000.
One dose. So there's no way you can give something to somebody unless the insurance approves it, and they just go by the book. It's a the setting.
There are many things beyond medicine that you need to consider when you're making decisions for your patient, and that point is also absolutely very well taken. So in case you guys have not understood, I'm talking about the audience, in case you've not understood anything at all, don't bother. This slide tells you everything that you need to know about neuroendocrine tumors. So your workup is very important, both the pathology and the radiology. I'm talking about the nuclear medicine workup, neuroendocrine tumor well differentiated, and then you have neuroendocrine carcinoma. Neuroendocrine tumors well differentiated are grade 1, 2, and 3 based on the Ki67. It's very rare to have a well differentiated tumor having a Ki67 of more than 55%. Neuroendocrine carcinoma is morphologically large and small cell. These are the 2 Ki67 ranges that you can have. Please do not forget that chemotherapy is a part of treatment for even patients who have lower Ki67. Dr. Namrata made that point. And please also do not forget that PRRT is an option for patients who have a higher Ki67 also. So the point is, you need to do both these scans so that you don't miss all the possible opportunities for therapy in our patients, because this is an incurable disease. So it's very important to make sure that you use as many therapies as possible in whatever sequence you think is appropriate, maintaining quality of life of your patients and making sure that you give the maximum longevity for your patients. So with that, I'm assuming that the panelists don't have any more comments to make. And I will thank all of you, and Viraj especially, for giving me this opportunity. Whenever I do a panel, Viraj, it's a learning experience for me, because I need to be, putting all this together. So I need to be a little ahead of the others. So I have to read it like as if I have read for the exam. So at least for tonight, I've got these figures in my fingertips. I don't know tomorrow morning. So I'll hand it over back to you, Viraj. Thanks so much for that opportunity. And thanks all of you panelists for being such lovely panelists. Thank you so much.